As an industry leader and pioneer of value-based care, Dr. Pearl is a personal hero to me. As a healthcare executive and champion for health value, his latest book um, is his prior book was one of my favorites, Mistreated, and this new book is a companion piece to that. And we're going to have a great discussion today about this important book, which takes the conversation further and helps us find remedies for our broken industry. We're going to spend a few minutes, or about 40 minutes, with the fireside chat, and we're going to have time at the end of the fireside chat with Dr. Pearl for you to submit questions. So please put your questions in the chat, and we're going to have a great time today. Well, we're going to have a very lively discussion, and Dr. Pearl, thanks so much for joining us today.
My pleasure, Eric. I look forward to our conversation and to hearing the audience's questions.
Well, before we start, I wanted to just mention the Accountable Care Learning Collaborative. We're a learning collaborative that was founded 6 years ago by Michael Levitt and Dr. Mark McClellan to accelerate the industry transition to value-based payment. So we have a learning collaborative where we do peer learning sessions like this. We release important intelligence and really are known as the industry convener for value-based care. So definitely check us out online. We'd love to talk to you if you're interested in joining. And let's go ahead and begin our conversation today. So today we're going to be discussing Dr. Robert Pearl's new book, Uncaring: How the Culture of Medicine Kills Doctors and Patients. And it tells the story of a profession that's both triumphant and dangerously flawed. It's filled with people that aspire to help others, but sometimes act coldly and callously and indifferent towards the pain of others. And this book does a incredible job of really telling you what's inside the doctor's world and reveals important insights about their training, their daily practices, and the culture that they share. It's really a book about striving for perfection in what we do and about the possibility of getting there. The book highlights what doctors can do to identify opportunities to improve and really take it upon themselves to form more impactful relationships with colleagues and patients. I did want to mention all profits from the book go to a wonderful charity. Dr. Pearl, you're so thoughtful about supporting Doctors Without Borders. So definitely wanted to let everyone know that, and certainly wanted to invite all of you who have those in your circle, your family, friends, physician colleagues. If they could benefit from reading this book, while you order one on Amazon, you can get the second one for 50% off. So it's a great way to give them Uncaring for those people that you care about. So without further ado, let's go ahead and kick off our conversation today. Again, feel free to type your questions in chat. We're going to be monitoring that throughout the discussion today. And, Dr. Pearl, I thought a great place to start our conversation would be to actually define what culture really is and how that applies to the medical profession. I mean, culture really seems like an abstract, complicated, and often confusing term. And I know there's libraries that are filled up with resources about the impact of culture on the human civilization. And there's doubtless intellectual and sociological merit in sorting through all of that, but your book does a really exceptional job of really outlining the important facets of physician culture and provides a foundation for really understanding, as I mentioned earlier, what makes doctors tick. And for those physicians out there that may be focused so intently on the structural reforms of healthcare, and you covered that in your first book, Mistreated, there's also a great opportunity to really have introspection around the cultural dysfunction that may be staring them in the face. So I wanted to start off today by just getting some of your framing thoughts around this important topic of physician culture and how we should be thinking about it as an industry.
Physician culture, actually, as you say, every culture is a combination of the beliefs, the values, and the norms that people hold. They're not found in any textbook. They're not heard in a lecture hall. They are communicated from one generation of individuals to the next through the stories they tell, the language that they use. When I wrote my first book, Mistreated, the Washington Post bestseller, I went around the country speaking at conferences, talking to hundreds of doctors, and they all understood the problems of the system of medicine today, a fragmented insurance network, hospitals that were consolidating for market control, not to improve quality or gain added effectiveness and efficiency of care, drug companies that were simply out for the highest profit. But as I talked more and more to them, there was something else out there. What came to my mind was the caduceus, the symbol of medicine that's on the white coats of many doctors, the book covers, the two serpents, the two snakes wound around a staff. And I realized that this is the medical reality. There's this system that is problematic, and then there's the culture. And the two are related, intimately entwined. You can't separate one without the other. That the culture of medicine is both a remarkably positive force. During COVID, it's what allowed doctors to go take care of patients 12 and 24 hours a day. It's what allowed them to do so when they didn't have the protective equipment. They donned garbage bags and salad lids. They passed tubes into patients' lungs, knowing that as the tube went through the vocal cords, patients would cough, spewing virus in their face. But it's also a system that created problems, that created ways in which physicians overlooked opportunities in chronic disease, opportunities around racism, opportunities around inefficient care that we can discuss a little bit later on. But that's the physician culture that exists. It's a wonderful culture. It involves opportunities of repression and denial about risks, allowing the doctors to be heroes. But it's similarly a culture that allows them to repress emotions in a way that they fail to talk about the things that are paining them, and as a result, inflicting harm on both patients and doctors.
Well, Dr. Pearl, I wanted to ask you about the juxtaposition that we have between physician culture and reforming it for the future, and then also the health policy reforms that are currently underway. Looking at the systemic reforms that have to happen to the healthcare system itself. And as I mentioned, your prior book, Mistreated, did an exceptional job at really looking at some of the structural flaws and those gross distortions and perverse incentives that are all too known, that really creates a dysfunctional business of medicine. But in Uncaring, like I said, it's this ideal companion because it confronts those broken aspects of medical culture. And I can't help but think about the kind of the chicken and egg situation we have here. I mean, how do you fix the physician culture without fixing the system? And then how do you fix the system without addressing some of the deeply entrenched patterns of behavior and physician culture that often make it impossible to deliver value-based care? Could you speak a little bit about that dichotomy and how we should be approaching this at a national level in terms of really getting the new generation of physicians aligned to the future, but also, those that have been in practice for decades? Like, how do we get them to look at the practice of medicine differently?
You're absolutely right, Eric. These two are intertwined, as I said, like the snakes on the caduceus. But let's just take one aspect. In addition to being a physician, in addition to having been the CEO in Kaiser Permanente for 18 years, I also teach in the Stanford Graduate School of Business and the Stanford School of Medicine. And I follow the economics very, very closely. And this book sprung to a large extent from December of 2019, 2 months before the coronavirus came ashore. And the federal government put out an estimate that the cost of medicine would go up 5 to 6% a year, every year for the next decade. It's compounded percentages, and when you do the calculation, it's about a 70% increase. Healthcare is going to go from 3.7 trillion to 6.2 trillion a 2.5 trillion increase. And I said, is this going to be the best way to spend money? What about if we use this for the social determinants of health, prevention, education? There are so many different ways the money could be used. And I waited for one of the organizations in medicine to step forward and say, this is absurd. Let's find a different way to provide care and use this money to improve the health of people. And I waited and waited and waited. Not a single one stepped forward, because in the culture of medicine, in the physician culture, the way we do things is the right way. So if that's what it costs, that's simply what it cost, but it didn't make any sense that's there. So the evolution, I think, is going to start with an economic change. When I look at the post-coronavirus era, what I see is that the federal government will have incurred about $8 trillion of added debt it needs to pay back along with interest. The states by law have to have balanced budgets. I saw that even California, that has Netflix and Amazon and Google and Facebook, is facing problems because of the growing number of unemployed Californians and the Medicaid costs that are there. And the small businesses, these are the engines of employment in the United States. Many of them went out of existence. The ones that are still there, a third of them saying they can't survive a year without continued government support. But we're going to see a lot of downward pressure on healthcare. And this is going to challenge the culture. And I think we're going to come to realize that the fee-for-service approach simply can't control costs, because it'll just lead to higher utilization, whether those things add value or not. And what we're going to see is a choice between rationing and transformation. And I'm hoping that that transformation, that physicians will embrace the idea of capitation, the idea of having a single payment going to a group of physicians and hospitals to care for a given set of patients, the whole accountable care model, but paid at the delivery system level. Because I believe that once that happens, the culture shifts. All of a sudden, when you're responsible for delivering care with quality and service monitoring in a fixed amount of dollars, you start to value prevention, avoidance of complications of chronic disease, patient safety. You start to avoid the 1/3 of medical care that the Mayo Clinic has shown to add little or no value. You embrace technologies such as telemedicine, ones that we've known about for many, many years. We just haven't used because it's gone against this culture, a culture that elevates seeing the patient in the doctor's office rather than providing the convenient care to the patient. And I think the culture will start to shift as a result of the economics coming out of the coronavirus, rather than starting with the culture having to change and then expecting that it will impact the system of care delivery.
Well, Dr. Pearl, I couldn't agree with you more. There's an economic necessity, and that's going to, there's going to be innovation born out of that. But we have this legacy model that it's going to be, a seismic shift, not only in terms of driving, better economic outcomes and better patient outcomes, but there's this cultural, almost a caste system, and with physicians where you have a disparity. You have the haves and the have-nots almost when you look at the degrees of separation and physician comp, and then ultimately status that's afforded to, at the top of the pyramid. You'll have rock star types of specialists like cardiologists and neurosurgeons, and then the more, the next level down might be some of the more general interventional specialties like gastroenterologists and orthopedists, and then at the very bottom, of this caste system, you have primary care. And you mentioned the importance of prevention and how that's really going to drive better economic outcomes for our healthcare system. And I think about, to have prevention, you really have to have a relationship-based, patient-centered, tech-enabled, interdisciplinary model. And primary care is so foundational to that, because it drives, it's upstream of about 80 to 90% of the costs that are really incurred in the inpatient setting. So as we look at kind of right sizing the industry and some of the cultural shifts that are going to be underway, how do we almost obliterate this cultural hierarchy and within the physician profession, the medical profession, and really give primary care the prominent position it rightly deserves, to give American healthcare a fighting chance to be fully transformed and to really drive a more improved future for our industry.
Well, I flip it around, Eric. I don't think it's a question of us doing it. I think the reality is that if we don't do it, someone else is going to displace the current system. Now, that sounds so impossible to many people. How are you going to displace the current system? And I have one word for people who are doubtful, and it's Amazon. If you just look what Amazon is doing today, or actually go back even 3 years when Amazon joined together with JP Morgan Chase and Berkshire Hathaway to form Haven. At the time, I wrote that anyone who thinks that Jeff Bezos is doing this, as they were saying, just for their own employees on a not-for-profit basis, probably believes that Amazon only sells books. No, no, this was going to be a major retail venture, the same way that it is in all the lines of business. And with Bezos having 1/6 of the retail business, they want 1/6 of the medical business. Now, if you're Amazon, the first thing you're going to do is get rid of insurance companies. Why do you need insurance companies? You got plenty of resources. You got more than enough cash. Why should you pay someone else 4% or 6% to manage your risk? The second thing is any idea that they can have all the hospitals in their network. Why would they do that? They're going to pick the best ones with the best outcomes and do their sophisticated procedures there. They're going to rebalance specialists and primary care. I mean, everyone knows that adding 10 primary care physicians to a community increases longevity by 2.5 times 10 specialists, and yet we keep training more specialists and we create jobs for them and ways for them to make money. Amazon's not going to do that. And already we can see, as they put into place many of the tools, they're offering telemedicine across the United States today. And they're not going to have every doctor in the community providing it. They're going to find the best people to do so. And so the idea that the current system is going to have a long-term survivability, I think, doesn't exist. And so that's why I wrote the book Uncaring, How the Culture of Medicine Kills Doctors and Patients, because it's going to happen as physicians start to look at what is going on, and I think to start to make the changes that are there. Now, having said that, I do want to point out that physicians tend to believe that it's money that drives the desirability of specialties, and I would say it's the opposite. It's what we do inside the culture that ultimately leads, in general, to the money that is paid out. And that we've done this to ourselves inside medicine. We've turned primary care into a less respected specialty. Now, why? And this is what's so interesting to me about the culture of medicine. It's the fact that we're now so much more successful. That sounds strange, but what do I mean by that? Well, if we have evidence-based medicine, if we can embed it into technology, if we can have common expectations for how to do things for the majority, not for all of the problems, but the majority of problems. In the culture of medicine, we look down upon that because we still value what was left over in the last century. You know, culture is learned in medical school and residency. It's 20 years out of date for the mid-career physician sitting there. In the last century, we didn't know how to prevent disease the way we do today. We didn't know how to treat disease. We didn't have the technology of today. So we built a culture that elevated not just the intellect of physicians, the ability to memorize arcane facts. And how do you get into medical school? You get chosen because you did well on the test coming into medical school. How do you get the best residencies? You did well on the test, the step 1 test, judging all those pieces. That was 2000, 7 years before the iPhone. If you wanted to know everything in medicine. You had to carry a 50-pound backpack. We elevated the people who could memorize all of that. We have smartphones today. It's a different set of skills. We still retain from the past what we believe in. And so I think it's going to become incumbent upon us, starting in medical school, throughout residency, in our communities. And that's why I think this moving from fee-for-service to capitation will make a difference. Because if you're going to have an integrated organization taking that risk, now they're going to have to elevate the individuals who are providing that prevention, who are avoiding the heart attacks and strokes that put patients in the hospital. It's why you see, as you know, in every large medical group, primary care is seen much higher than in the community in general. They're paid better than the community in general because their role is seen and valued. I go back to this in this arena to the same point I made before. We're going to have to move the reimbursement inside the system of medicine in order to move the culture. Having moved the culture, then will change the way the system of medicine works.
Well, Dr. Pearl, you spent a great deal of time kind of talking about this necessity that we have to shift the culture and the survivability of the healthcare industry. And I have to ask you about really the survivability of physicians. We hear it a lot, and Don Berwick coined it perfectly with the triple aim. And now there's the triple aim plus one, which is really thinking about not only lower per capita cost, better patient outcomes, better experience, but that experience of the provider. And I know there's a lot of physicians that are lamenting the how the profession isn't quite what it used to be. I mean, they're even telling the youth and their own children, don't go into medicine. I wouldn't recommend it as a career. Clearly there's doctors are really, they feel like there's a lot of administrative requirements that are unnecessarily posed on them that creates a wedge between them and the way they want to treat patients. There's the whole art versus science debate, and as we move into evidence-based models, physicians they're struggling with depression. I mean, there's data now that says 15% of physicians at a given time are struggling with depression, and 20% have reported even having suicidal thoughts. And then there's even a significant amount of physicians that are saying, don't call it burnout. I mean, call it what it is. I mean, this is moral injury. And, we certainly saw, the case to be made about moral injury in terms of, the COVID response and, physicians being on the front lines. And, we often use like this military language when we even talk about the profession, the front line and, those in the trenches. And, so it just seems like physicians are beleaguered. They're dealing with burnout and maybe even moral injury. And as we look at the cultural changes that have to happen, how do we create a better environment for physicians that are not only in practice but inspire a whole new generation of people to take the mantle and become physicians themselves to make our country better.
You're absolutely right, Eric, that there are massive systemic problems, and you've outlined some of them. There's an ongoing pressure for doctors having to see more and more patients a day. There are the authorizations from the insurance companies that in some cases, if you take all the time of documentation, there's more time spent fulfilling the bureaucratic tasks and actually touching and seeing the patient. There's the electronic health record that's designed around billing. The system is completely broken. And that's why I wrote Mistreated. It's all about the systemic problems that exist. But I also want to add the cultural ones, because I think in the people who are expecting change to happen, it's not going to happen. Doctors have been talking about these issues now for how long? 5 years? 10 years? Do we think we haven't yelled loud enough? The culture has to also move. And I will tell you right now, there are doctors probably watching right now who aren't going to like what I'm saying. But I think it's the reality that's there. We may think we're entitled to something else, but we're not likely to get it no matter how much we complain about it. And I think we have to be willing to be a stronger part of the solution than just the problem. I think the idea of just let doctors be doctors isn't going to work, because today, this is not 50 years ago, medicine has become so much more complex. It needs to have a leadership structure. It needs to have evidence-based practices. It needs to have more commonality and less variability in order to meet the needs of people. 20 years ago, medicine was a paternalistic society. We told patients what to do and they did it. That day's gone. I agree that medicine's not what it used to be, but it's not coming back. Patients are not going to be less demanding than they were. Patients go to the internet. They have information. They want the physician to address it. They don't see the physician as the ultimate source. They see the physician as an advisor, the way you might think of a travel agent. We hate it. We think the internet's full of bad ideas. That's not going to change the reality. Kubler-Ross wrote about this, and many of the points she just made, she spoke about. Denial. We deny the fact that we have to change. We think the world has to change. We deny that we play a role in it. But as I say, the Mayo Clinic has published data. This is a third of what we do, doesn't add a whole lot of value, and we still continue to do it. The opioid epidemic was definitely driven by drug companies and the very egregious and very immoral CEOs. But we wrote the prescriptions. We may not like that. We had telemedicine for 7 years and we didn't use it. I could go down the whole list of pieces that are there. If we want to say that we're perfect and the rest of the world is broken, Eric, I don't think anything's going to change, and Amazon's just going to beat us to the punch. But I think that we can make that evolution happen. So denial is the first stage. And then there's anger. And a lot of the moral injury, I think, comes out of that anger. And people have a right to be angry. I mean, why should the insurance companies get in our way? Why should those computers be so slow? Why should we see our income every year be diminished? They're all right about that, but we're going to have to come up with a better system, because right now Americans can't afford the care that we provide, the care that they deserve, the care that they need, and rationing is not a good answer from my viewpoint. The third part is bargaining, and we're seeing that. I think last month or the month before, more doctors now are working for someone else, usually a hospital, than in their own practice. But that bargaining is not going to work. At some point, the Amazons of the world are going to say, we're not going to contract with your hospital at all, including your doctors. We're going to go to someone else who we think is higher quality and can do it for fewer dollars. And then there's depression, and you're absolutely right. I'm very worried about this, particularly the post-coronavirus era. Again, go back to residency even 20 years ago. Residents were working 100-hour weeks. Now they only work 80? Is that only? I mean, come on. How does that make sense? You taught, never talk about your pain. Never talk about your feelings. Feelings get in the way of the doctor-patient relationship. We've got to change all of that, particularly the post-coronavirus era, where we're going to see a tremendous rise, not just in burnout, but depression and suicide. I've talked to doctors who have lost 4 patients in a day, residents who started the month with 6 patients in the ICU, and they were all dead by the end. You just go down the list of opportunities that are there. We need to recognize, as you say, that we're human, but that doesn't mean that we don't also contribute to the problem and need to make some changes. And it's ultimately acceptance. And that's where I'm hoping, in reading the book, people are going to come down to. You're absolutely right. Medicine is not what it was 20 years ago. By the way, we still attract amazing people into medical school. They come there on day one and they are so motivated. And you know something, Eric? By the end of the first year, they're reporting the same rate of burnout. They haven't had to go through an authorization process. They haven't touched a computer, and they're just as burned out. And how is that possible? I think a major part of that is this disconnect. There they are, memorizing a bunch of facts in a world of technology. The last thing I would ever tell a medical student is don't bring your smartphone to an exam. If you can have the smartphone in your examination room, take it to your exam, and we're going to test you on how can you use that information to provide superior care to patients. It's acceptance that the world is different. It may not be as good as we had it before, but it can be so much better than it is today. And that's what I'm hoping the readers of Uncaring will finish with. I wrote it out of a desire to make sure that the next generation enjoys the profession as much as I have. The best decision I made professionally in my life was becoming a doctor.
Well, Dr. Pearl, it's great to hear that sense of optimism, and I share in that. I mean, it's going to be painful, any transition is, but you look at exemplars like ChinMed that are delivering patient-centered care. They have a physician culture that's top notch, and there's a great sense of professional satisfaction. We've talked a lot so far about this evolution that's taking place, both in terms of the structural model of care delivery and moving from fee for service to risk-based models, and then also this physician cultural element. But there's one other major shift that's happening societally, and I wanted to land on this before we get into some of the audience questions. But we've come out of a pandemic that's shown a great societal awareness around racial disparities in care, and we've had a social justice movement that's been underway. There's now a sense of awareness that there is a pervasive sense of institutional racism that unfortunately favors whites over those of colored skin, in terms of looking at some of the irrefutable evidence around outcomes and poor health indicators. And there's I'm sure a faction in the physician culture that would question some of the data that we see, and they'll say, well, those are driven by social determinants. That's where the people are in the communities, and where that has nothing to do with healthcare. I wanted you to speak a little bit about the where the culture is currently and how it supports what many call an institution that does have racism, at least in the terms of providing a care model that does have disparate outcomes. And then where does it go from here in terms of the cultural awareness within physicians, and then ultimately creating a better sense of health equity for the future?
You're absolutely right, Eric, that the disparities in outcomes is massive in the United States. What we see is that Black individuals have died from COVID 3 times the rate of white individuals. And if we ask doctors about that, exactly what you're saying, they'll blame it on the fact that Black individuals often have jobs that require that they go there rather than being able to be on Zoom safely from their home. They'll point out they often travel on subways and buses that are filled with people capable of spreading disease. They live in multi-generational houses. There's a long list of societal pieces, and they're all accurate. Again, this notion of the caduceus and the two snakes. But none of those explain some of the facts. As an example, in the culture of medicine, what do we tell ourselves? We treat every patient the same, at least based upon their symptoms and physical findings. Then how do we explain that early in the pandemic, when there was a shortage of testing kits, the doctor might have 3 kits for the whole night, and the kits were used on white patients twice as often as Black patients who came to the ED with exactly the same symptoms, despite the fact that Black patients would have a higher chance of dying? What do we do about the fact that we gave 40% less pain medication to Black patients after the same procedures as white patients? And if anyone thinks this is just COVID data, New England Journal of Medicine, I think last week or the week before, had an article about how patients with chest pain and other symptoms that could be a heart attack were tested twice as often if they were white patients, and given intervention twice as often as white patients than if they were Black patients. The list goes on and on. Every study has shown the same piece. Now, this is what I think a really interesting part, because you have to ask yourself, okay, why? I would say that none of these people think of themselves as racists. None of them think they're discriminating. So why do they if it's not conscious, if it's not intentional? And the answer that I talk about in the book is implicit bias. And implicit bias, I believe, is left over from 20,000 years ago. You know, there you were sitting in a cave somewhere and you saw a human form appearing over the horizon, and you had a nanosecond to decide whether to open your arms and greet someone from your own tribe and welcome them to your cave, or to take your arrow and shoot it at them, knowing that it was someone from another tribe coming to kill you and take what you had away from you. We developed this skill. It's called thin slicing, and we can do it exceedingly well without being aware of it. That's what's key about this ability. And implicit bias is part of that. We just don't see people who have a different colored skin, speak a different language, worship a different God as being part of our tribe, not because intellectually we think that way. It's just the way the human body responds. And I was on a podcast a little while ago, and a caller asked me, said, well, is implicit bias racism? My response was no. Implicit bias isn't racism. It's just part of our human response. But knowing it exists and not doing anything about it, that is racism. And that's where I think that we are. And that's the culture of medicine. If we want to keep telling ourselves and reassuring ourselves that we don't deliver two different levels of care dependent upon someone's color of their skin, their socioeconomic status, the language they speak, we can tell ourselves that. And we can pretend that everything is good, or we can say, no, we don't intentionally do it. We're not intrinsically discriminating, but that is what happens as a result of our actions. And knowing that, we're going to put in systems to make sure that when we prescribe a lower dose of pain medication than usual, the computer is going to say to us, are you sure you want to give this? It's less than your usual. When we test patients with symptoms or don't test patients with symptoms, a computer system, some kind of way is going to say to us, are you sure you don't want to test this individual? Now, in the culture of medicine, the last thing doctors value is being questioned, particularly being questioned by a computer or an algorithm. You know, we call it cookbook medicine. The truth is that the data says we elevate the overall performance dramatically. You know, people say, is that going to take the great and make us all mediocre? The answer is no. It's not going to lower the people at the top. It's going to raise people at the bottom and the middle, so the overall is far better. But the culture of medicine is going to sit right in the way, because when those things happen, people are going to say, well, maybe doctors aren't so great. There are alternative ways to do it, or people are going to say, oh my gosh, AI is going to replace physicians in the future. I think that acceptance is saying, here are the changes that have happened in the values, in the knowledge, in the medicine, in the technology. And now that we know that, here's what we can do to maximize that on behalf of both our patients and ourselves.
Well, Dr. Pearl, thank you so much for the thoughtful responses. I'm going to now pose to you some audience questions. And the first question comes from Dr. Gary Wayner, the Chief Medical Officer at Innovista Health Solutions. And, he says, Dr. Pearl, I couldn't agree with you more. I'm very curious about medical education. Are there any medical schools taking any effort right now to influence physician culture prior to those students going into the real world of medical practice?
Well, Gary, thank you for your efforts helping to lead the change as well. I mean, obviously, I know a little bit about the Kaiser Permanente Medical School. It's in Southern California, but servicing the entire nation. And it has some of these concepts built into it. But it requires a really radical shift, I think, across the whole industry. As I said, we have to give up the things that we think are most important, because those skills were left over from the last century, and move forward into what we want to be accomplishing, which is often going to be that relationship with the patient. And we have to therefore learn new ways to screen, rather than asking tests that are dependent upon memory and dependent upon arcane factors. That's all you can test for on a multiple choice examination. As I say, I think we're going to need to build in ways of asking, how do you use a smartphone? to be able to provide that care and recognize that no longer can we tell patients what to do. We have to recognize them and accept them as partners. We still coming out of a history where we were the sole purveyors of knowledge, still see that world as being the right world. And I'm not going to argue whether it's better or worse in terms of outcomes, but what I will tell people is that it's not going to be the future. It's going to continue to advance, and we're going to find patients claiming more and more of their own care and our role having to shift. So I think it's going to change there. But even beyond medical school, I think residency is where the biggest learning happens. That's where we observe our attendings and our chief residents. That's where we try to, I'll say, I don't want to say mimic, but to imitate the things that they do. That's who we see as being the best and right ways to become doctors. And one of the questions in a piece that I wrote for the LA Times about a month ago around this question, the last thing I said is at the end of every day, on every rounds, we need to have people ask themselves, did I treat every patient the way I'd want for my own family, for my friends, for my loved ones? And I'm going to say, I don't think that most doctors can say yes to that question. Having said no, we can blame it on someone else. The demands of the residency, the demands of the insurer, the problems with regulators. But I think that we need to see that and take moral umbrage as much about that, the things that we control as the things that are done to us, or at least not be able to deny our role in doing so and to make the changes that are there. It's going to take some very strong leaders who are willing to buck what has been a centuries-long tide. But I believe that it can get done, and I believe it, once again, that if we don't do it, someone else will do it to us, and we'll regret having missed the opportunity to lead the way.
Well, thank you, Dr. Pearl. The next question comes from Jessica Taylor, and she's responding to some of the earlier comments you made around Amazon being a disruptor in industry. And she's thinking a lot about the influence of large employers on the future state of healthcare. And she wanted to ask you specifically about direct to employer contracts and what role will they play in the future of value-based care?
Jessica, this is a really important question that you've asked, and I can't see it not continuing to move in the direction it is, which is that more and more large employers providing their own healthcare coverage and their own direct contracting around it. Right now, what we see are intermediaries. We certainly see companies like United doing a lot of this work on self-funded companies, but it's only a matter of time. And Jeff Bezos has already talked about the fact that other companies are approaching him to do this with a recognition that they're going to do it in a very different kind of way. And I think that these kinds of, I'll call them disruptive innovations, happen in conjunction with the demands around them. And in particular, I think that telemedicine will be a big piece around it. That until we had telemedicine, medicine had to be local. And I think what businesses are going to recognize or are recognizing is that no, there are some things that have to be done locally. If you can't breathe, you've got to get to the nearest emergency room. If you're having a stroke or heart attack, you have to get to the nearest center with the capability of reversing it. But so much of what we do is really not geographically constrained in theory. And they're going to find ways around it, and they're going to find the approaches are better than these third-party intermediaries. They're going to get away from payment through reimbursement of fee-for-service. They're going to move towards I'll call it a capitated budget, but since it's their own budget, it's really going to be a limiting one that's going to maximize the quality and maximize and lower the cost. The challenge they have right now is figuring out how to make it happen, because there's not a lot of people who have already done it. And Eric, the organization you're with, is a good example of one that can help lead the way as they move towards accountable care type delivery structures, again, not capitated at the insurance level, but capitated at the delivery system level, led by clinicians who understand what needs to do and have the technology to accomplish it.
Thank you, Dr. Pearl. Next question is from Khadija Ngawi. The question is, what is the role of ethical standards and responsibilities in shaping and shifting the culture of medicine?
I think our whole profession has such a foundation in ethics and values. We have first do no harm. We have a belief in treating everyone the same. So we have the ethical standards, but what we have not been able to do is to recognize the ways that we don't always adhere to them. Now, when we say first do no harm, it sounds very, very important. And yet, does harm include the fact that healthcare is now the number one cause of bankruptcy for families? Again, a lot of doctors won't like what I'm about to say, but surprise billing that puts the patient in the middle feels to me a little bit similar to when in war-torn areas, civilians are placed near military operations with the hope that the enemy will not bomb the area and kill innocent people. But it's not the right thing to do. And the new legislation out of Congress, of course, will shift a lot of that, but it's still what we did. And we continue to prescribe the opioids, even when the data said harm was being done. And we have a lot of data on the impact of device manufacturer payments to doctors that just came out this week. And we have physicians taking hundreds of thousands of dollars and $500,000. And they can tell themselves that it's because they're so smart and they're giving ideas to the device companies. But the truth we know is that they are doing it because they use a lot of the product and the company has a huge markup. And the same occurs when doctors go to fancy dinners with drug companies. A lot has become less, and the sunshine laws have helped. But there are so many ways that we violate that ethics. And that's why I go back to that simple question. Did we treat everyone the way we'd want for our family and friends? Now, I know that there's so-called platinum, rather than the golden rule, the platinum rule, that you should make sure you treat the other person the way they want. And that's even better because people might want care differently. But if you're not yet treating everyone the way that you would want, then I think there's a problem that exists. So I think ethics is there. I think medicine is the most ethical of areas. Don't get me wrong. I mean, so many other areas have far greater ethical problems. It's just that our standards just need to be, from my viewpoint, that much higher. And where there's a gap, it becomes an imperative to make change, because if you see a problem and you don't act on it, you become part of the problem. And I fear that that's a lot of what the physician culture has done today, and this repression and this denial that are in place for good reasons. I mean, remember, across time, there was so little we could do. Imagine the doctor holding the child, knowing this child's going to die, the parents in tears. How does the doctor deal with that every day? How do you get up the day after losing 4 patients from COVID and return to that critical care unit? You need that to be a successful physician. But we also have to recognize that when it goes beyond that, to the point you're making around the ethical issues, around the right things for patients, around inflicting harm on people, that's when we have to recognize what we're doing and make changes. And I believe that that's where we are right now as a profession. And in writing the book, I'm hoping to move people in that direction.
Well, Dr. Pearl, I have another question for you. This is from Andrew Coppola, Associate Director of Operational Excellence at United Healthcare, and he's also adjunct faculty at Jefferson. He has a question around the direct primary care movement. He wanted to know your thoughts on companies that are offering monthly subscription services such as Cloud Medical out of Colorado. that removes payers out of the equation entirely? Is there value in that type of delivery model?
Well, I don't think you can move payers out of healthcare. It's just too expensive to get medical care. So someone's going to pay for this, and we know that the average family in the United States can't afford it. I think the question, though, is how do you move from a system, a fee-for-service type system, into a capitated one? And it sounds like it's simple, and it's very hard because you've got to put together this network. You've got to have a large enough population. There are a lot of changes that need to happen. And even though at the 10-year mark it may be so much better than at the start, you can't get there because of all of the lost revenue, whether you're a physician or whether you're a hospital along the way. So people often ask me, well, why isn't Kaiser Permanente in more places? And the answer is really not, it's not about the problems in the model. It's the problems in getting the model implemented. You need about 100,000 people in the geography of about a circle of 15 miles in order to have a hospital. And without having a hospital, now you're back into the system of old. You need to have populations of that size to have enough specialists to provide the care. And until you get there, you can't, that size, you can't do it, and you can't provide the coverage. So it's all the limitations along the way. The primary care model, though, is a great first step. Now, why is that? And why is it really, in many ways, I'd say, the most successful new model? There are models left over, by the way, left over, I mean, that started 60, 70, 80 years ago. The Kaiser Permanentes, the Mayo Clinics, the Geisingers, the whole list of accountable care organizations that are out there. But of the new ones, they're almost all in the primary care mode. And the reason they can be successful is two things. Number one, they can use technology. So they can have a bigger area upon which to draw. They can create opportunities to create volume so that doctors in different places can help out with each other. The opportunity, it's only 6% of the total healthcare cost, and a subscription model now allows enough added revenue to come in to allow a much lower ratio. You mentioned ChenMed earlier. They have panel sizes that are about half that of other organizations. You can look at a company like One Medical that's able to do it by being able to have an enrollment fee that provides enough added income on that denominator base of primary care to have a much better day-to-day practice style. There are a lot, so it's an easier first transition, but it's just the first transition. And I only say it's the first transition. I often tell people 80% of what adds value is in primary care, 80% of what adds cost is in specialty care. And we have to be able to figure out the next level, which is the specialist. And that's where I think, again, that telemedicine will be a big piece. And it will still require that there be someone paying the bill, whether it's, the reason that ChenMed works as an example is because it's Medicare Advantage. The government's paying the capitated fee. And the reason these other models could work is because a commercial firm will pay it or a business will pay it. And when you start to build this specialty care on top of the primary care and you add in the hospital, now you're starting to get to a point where you're encompassing the majority of care. And you can make sure that you lower additional demand by prevention. You can have better utilization of the drugs that are out there, better utilization of the technology. I often talk about how physician culture is left over from the last century. And I think about a time when I went to the health services department in Oregon. And there on the wall, I saw quality, service, cost across the top of a poster. And below it, it said, pick any two. That's the mindset of the 20th century. We can't have quality and service and cost. We can only have two. Now you start to ask yourself, look at a simple thing like telemedicine. If you can give care immediately, if you can give care, by the way, 24 hours a day, not just 8 hours, 5 days a week when the offices are open, and send patients to the ED the rest of the time where they're not going to get definitive care. but you can leverage a bunch of physicians, each taking one day every 2 or 3 weeks or whatever the numbers are going to be. And now you can use telemedicine, a lower cost service. Or you look at the opportunities across a weekend. Admit to a hospital on Friday, you're going to spend an extra day in the hospital. And with the same diagnosis on a Monday or Tuesday, and look for ways to move from a 5-day care delivery model to one that's 7 days, not by adding costs, but by finding ways to spread the care across all 7 days. Getting better a day faster is better quality, it's better service, and it's lower cost. Everything that I talk about in both books is about ways to increase quality and service and lower cost. You know, we've started by saying, how do we lower costs? And whatever happens to quality of service is a byproduct. I start the other way. When I was CEO, how do I raise quality? Because if I can prevent disease, I can lower cost. How do I provide technology? Because I can make the care more convenient and patients don't have to miss work, and I can do it with technology. It's lower cost, it's better quality. But in the physician culture, it's not as good as the doctor's office. It's not as good as the ED. It's not as good as being in a hospital. Those ideas are left over from the last century. Hospitals are places where patients can get hospital-acquired infections. EDs are places where triaging whether they get admitted or not with long waits for anyone who's not critically ill. You go down the list of areas. It's the culture that needs to change, shifting the things that we value to what is now available. And I think that when the quality is up, when patients are more satisfied, when care is more affordable, I think that physician satisfaction will rise. I think that burnout will diminish. I think that fulfillment will increase in the profession. It's not going to be an easy journey, Eric, but I think it's one that we will be glad we went on and be disappointed if someone else gets ahead of us.
Well, Dr. Pearl, I am so grateful for you and your leadership. I mean, you've demonstrated that we can deliver all three. You know, from going back to your days when you ran Kaiser Permanente Medical Group to your thought leadership now. I mean, we truly can, as a country, have better outcomes for patients, better experience, lower costs, and an improved physician culture. I want to commend you again for saying this important message. I can only imagine, you know, some of the, you know, you probably have a few 1-stars, you know, just based on the title of the book, but it's an important topic. It needs to be confronted. And I think that this is going to ultimately, as we have this economic necessity, there's also a moral imperative to do the right thing. And as Americans, sometimes we create problems, but we're really good at responding to a moment of crisis. And I believe we're going to rise to the occasion. And your leadership in making this happen is so greatly appreciated. So we're honored to have you today, and thank you so much for taking time to answer questions for our attendees. We are up on time. I did want to announce our next event on the 29th. We're having a peer learning session on the digital health landscape. You'll see a save the date and some registration info forthcoming. And again, Dr. Pearl, thank you so much.
Eric, 2 things for your listeners. If you have any more questions, you can send them in, and I'll be happy to send you back some answers through email. Check out my website, robertpearlmd.com, if you want more information. And once again, all profits from the book go to Doctors Without Borders, a wonderful organization providing relief around the globe. Thank you so much. I appreciate the opportunity to engage with you today, Eric. Thank you.
Thank you, Dr. Pearl.